Thank you for joining us. I'm here today with Dr. Niall Roche, Director of Rheumatology at ValleyCare Health System, and we're going to be talking about rheumatoid arthritis. Dr. Roche, if we could start, please, could you share with our audience what rheumatoid arthritis is?
Rheumatoid arthritis is a chronic inflammatory disorder that primarily affects the joints, especially the small joints of the hands and feet, but can affect other parts of the body as well.
Okay, and how does it differ from osteoarthritis?
Well, osteoarthritis is often referred to sort of wear and tear arthritis. Everybody eventually gets a little bit of osteoarthritis. Rheumatoid arthritis is an autoimmune disease, and it's where the body mistakenly begins to attack the lining of the joints. And over time, then you'll see changes which in some ways resemble osteoarthritis, but are also distinct from it. The important point, I guess, is that the treatment is very different from osteoarthritis and rheumatoid arthritis.
Okay, so you mentioned hands and feet. Is that the only place that someone can get rheumatoid arthritis?
You can get rheumatoid arthritis in any joint, pretty much. But the common places are the hands, the feet, can also affect the wrists, the shoulders, the knees, the hips, and even the joint in the jaw. And at the top of the spine. So it can affect joints and also other parts of the body. So it's not just confined to joints.
I see. And is this a type of arthritis that just affects the older population, or can anybody get RA?
Actually, anybody can get RA. Even one of my youngest patients was 5 years old, and I have a patient who's about 96. So it's a big range, but typically will be a patient who is between the age of 30 and 60. And women are more frequently affected than men.
Well, again, that's not fair. We have too many of these diseases that affect that way. Dr. Roche, how prevalent is rheumatoid arthritis?
It's a relatively common condition. It affects about 1.5 million Americans.
I didn't realize that. What are the risk factors for developing RA?
Well, being a woman is a risk factor. If you have a positive family history, that's a risk factor. And age is a risk factor. So as people get older, certainly when they enter that 30 to 60 year bracket, their chance of developing rheumatoid arthritis is increased.
Okay. Well, clearly, obviously, we have nothing that we can do about any of those things. But are there any diet, any exercise, are there any controllable factors a person has?
There are not many things that can change whether you get rheumatoid arthritis or not. We do know that smoking is one possible risk factor. And there's some controversy as to whether perhaps certain kinds of infections, but you have very little control over. Apart from the smoking, there are very few things you can really do to prevent getting this.
Okay. What are the early signs?
The early signs are generally pain and tenderness, warmth, swelling, often affecting small joints of the hands. As you see here, it's where the fingers join to the hand, and then the joints which are close to the hand are more effective than the ones that are further away. So this is a patient with early rheumatoid arthritis. And an important point to note is that it often affects both hands similarly. So it's not a one-sided thing. It's often both hands are affected or both feet. There's a remarkable symmetry in how it affects the body.
Interesting. And does someone ever have it in several places, like they have it in their hands and their feet and their jaw all at the same time, or is it typically just hitting one area of the body at a time?
Well, it can affect many parts of the body. Sometimes the onset is fairly widespread, and sometimes it's a single joint, so it varies a lot. But I guess an important thing to say is that the pattern of involvement is one of the clues as to knowing which kind of arthritis it is. There are over 100 different kinds of arthritis. About 10 are common. And one of the ways we can tell that it's rheumatoid arthritis is the pattern of joints involved. For example, the fact that they're symmetrical.
Okay, so testing for this. I mean, obviously, as you mentioned, symmetry and where it's affecting is one of the things that clues you into that this is the type of the arthritis. But what other types of tests do you do?
Well, I think the most important thing of all is the clinical exam. So during a clinical exam, we take a look at the joints, and we also speak, for example, about more generalized. I mentioned it affects more than just joints. So often patients will in fact feel unwell. They may have fatigue, they may have fever, they may have other organ involvement. So that comes out in the history. When your doctor examines your joints, he takes a look at almost all the joints in the body and carefully makes a note of how many joints are involved. So that's the most important part of the diagnosis. When that part is over, we move on to doing tests. And for example, certain blood tests are extremely helpful, not to make the diagnosis. There's actually no single test that will tell you this person has rheumatoid arthritis or not. But a good example would be the rheumatoid factor. People have heard of this. And a rheumatoid factor is a marker in the blood of this condition. And another marker would be something called the CCP antibody. Now, they're both very helpful, but it would be nice to think that if you did a test, you have the disease, and if it's negative, you don't have it. But that's not quite how it works. Almost all patients with rheumatoid arthritis have a rheumatoid factor, which is positive. But you can have the rheumatoid factor and not have rheumatoid arthritis, and that's often a source of concern for patients.
Is it that you don't have it yet, or is it that you're never going to get it?
We're getting there. The anti-CCP antibody is a more recent test, and it's more specific. In addition to that, though, we use tests in the body which measure inflammation. So, for example, a test called the ESR, sometimes referred to as the SED rate, will often be elevated in patients with arthritis or inflammation, and also an even more sensitive test called the CRP. So when you get a patient who has a typical clinical picture and then you find they've got elevated markers for inflammation and you find perhaps a rheumatoid factor, an anti-CCP antibody, or both, makes it very probable that that's what this patient has.
I see. So let's say you diagnose a patient. Yes, they do indeed have RA. How do you treat them?
Well, I might just mention before moving on to that there are other things that can help a bit with the diagnosis, and one are x-rays. So doing x-rays can show you whether any bony changes have taken place. And it's also useful because it means that later, if there's progression, and often it's hard to remember exactly what things looked like on day one, so you can compare the x-rays over time. And even more specific tests might be MRI or ultrasound, although they're used less often because usually the clinical picture is sufficient. You don't have to send people for an MRI scan most times.
I see. So then you've taken a look and you've decided, yes, this is indeed what it is. Is it something that can be treated very simply with drugs, or is it something that requires surgery, or is there kind of a combination of things?
There are a whole number of things that are very important in managing rheumatoid arthritis. I think perhaps the single most important thing is education. So I hope people watching this DVD will learn something about the disease. The better you understand the condition, the better you're going to do over time. It's good to know there are drugs that can make a big difference. There are sort of two groups of drugs. There are drugs that control symptoms. For example, non-steroidals, anti-inflammatories, things like naproxen, Motrin, Aleve, Advil. Some of them you buy over the counter, some are prescription. But perhaps most importantly is that there are drugs that can change the underlying condition. And these are called DMARDs, which is short for disease-modifying anti-rheumatic drugs. There's a long number of these drugs, but I'll talk on just a few of them, if I may.
Please.
Some of the drugs have been around for a while. For example, we have a very good drug called hydroxychloroquine, which can be used. It doesn't work for everybody. That's the problem. Another drug which is used frequently is methotrexate. That was one of the big advances. That actually came about in the late 1980s, and it was something that began to change the outcome of the disease for most patients. But more recently, I'm happy to say that there have been huge advances. We have a subgroup of DMARDs called biologic response modifiers. These are long words.
I'm glad you know this stuff.
Just call them biologics. We'll call them biologics. Biologics are drugs which are basically, the inflammation is the end result of a long series of events in the body, and certain molecules control parts of the event. So by blocking some of the stages, you can block the end result, which is inflammation. So, for example, some of the drugs which are given by infusion would include things like Remicade, which is infliximab, Orencia, which is another infusion drug. Then there are other drugs, for example, Enbrel or Humira or Simponi, which are injected into the skin directly. And they can be administered once a week, once every 2 weeks, or once a month.
I like how you're using infusion versus shots, because it sounds so much more pleasant. Are these indeed shots into the joints that are affected?
Well, no, generally the infusion means that it's going into your arm.
Oh, okay.
So it's given literally as an IV, and it's usually done under supervision in a doctor's office.
Okay.
The other drugs I mentioned, like Enbrel, Humira, and Simponi, are actually self-injected. And patients after 1 or 2 goes get very good at this. Even the kids, when they know what a difference it makes, they're more than happy to do it. And more recently, a new group of drugs has come along affecting a different pathway called the JAK pathway, and it's a Janus kinase pathway. There's a drug called Xeljanz, which is similar to biologics in efficacy, but which can be taken as a pill. I might just mention that, like everything else in medicine, there are always pluses and minuses. So although the biologics are very effective, you've got to be careful about certain important side effects. For example, if you have a history of tuberculosis, we've got to screen for that before you begin, because these drugs can reactivate it. You've got to be screened for hepatitis, and you've got to be careful about infection. So although they're a big step forward, they greatly modify the rheumatoid arthritis, we've got to be monitored careful to use them properly. I always say to patients, risk comes from not knowing what you're doing. So whether you're driving a car or have a boat on the lake or flying a plane, it's really whether you know what you're doing or not that matters. So with the drugs, if you understand them and use them correctly, then they're safe.
Okay. Now, does the beginning of taking drugs for treatment, is the outcome different if someone starts taking it early on, at the early onset of RA, versus kind of far into the disease?
I think one of the key things to understand is that years ago our options were limited, so it made less of a difference. But nowadays, because we've got drugs which can actually change the course of the disease, the earlier the better, is very simply. Because I sometimes say to patients, you know, we can stop the clock, we can't return the clock back.
That was my next question. Is this reversible, or is it once you have this, but we can stop it from getting any worse?
The natural history of this condition is that it progresses. And I think we might have a slide here of a patient who, this is an old slide, and it's from a patient who was not treated. It's a slide of hands where you'll see some fairly advanced changes of rheumatoid arthritis. So here you see, you can see just how much damage that can be, and imagine the impact that has on a patient trying to function in life, opening jars or bottles or doing things. And if we compare the slide of the patient with the very first changes of disease with this after slide, or an untreated patient. So this is, up at the top you see some early changes, underneath you see some late changes. And I'm happy to say that nowadays, if you come in early, we can keep you looking like slide number 1.
Well, that's good to know. Now, how many years has the person in the lower slide had RA?
Probably 20 or 30 years.
And that was left untreated, this is what it's going to look like?
I still see patients like this in my practice, but they're usually older patients who developed this before we could make changes. I like to think that for the vast majority of patients now, if you come in early, we can make it that it's not there. People have to take medication, but we can more or less prevent any further progression of joint damage.
Okay. Aside from medication, is diet a factor? Is exercise, maybe occupational therapy? Does any of that help?
All of that helps. I think it's important to know that diet is not very important for your general well-being, and the same dietary suggestions regarding, say, eating more unprocessed organic food, vegetables, things like that, the healthy things we know in our diet, and avoiding the unhealthy things not only helps your general health but affects your arthritis as well.
How?
Well, it's just the way the body, it's almost like there's a battle going on between you and the disease. If you're in good health, generally, if you exercise, if you get enough sleep, if you eat well, and if you manage your stress, then you're a strong adversary for the disease. So when the disease comes along, the disease has a much harder job. Just on diet, I might mention that years ago, people thought that certain kinds of modifications, for example, eating nothing but black cherries or cranberries or something, this would make. Well, it has turned out that for the vast majority of patients, it really doesn't matter. But in a generally good diet is a big difference. So in addition to diet and exercise, and here I might mention physical therapy, because often patients are trying to exercise in the setting of limitation. So they've got some restrictions, and a physical therapist can show you, just because your knee is inflamed doesn't mean that you can do nothing with the rest of your body. You can do upper arm exercises. Water therapy can often allow you to exercise while protecting the joint. So a physical therapist will show you how to protect your joints, and they can show you exercise that work for you. In addition, occupational therapists are very good at showing you what kind of devices, and there's some very clever things. One patient actually recently gave me a tip, which I've used myself actually, which is if you're trying to open a jar, instead of having a special jar opener, just put on a pair of rubber gloves. And
like dishwashing gloves.
Wearing dishwashing gloves, and the great thing about dishwashing gloves, they're in most houses. So if you're away from home and you haven't brought your tools with you, you can get around. But patients are they're very creative in what they've managed to do, and it's remarkable.
I can imagine. Now, is surgery ever an option for someone, perhaps like the woman in the lower slide, whose hands were really, really far along? Does surgery ever do anything for this disease, or is it just not an option?
We hope that we minimize the number of patients who go for surgery, but yes, surgery is useful. If a joint is destroyed, then replacing that joint, let's say a hip or a knee, can totally change the quality of life for a patient. Sometimes tendons can be affected by the disease and they can rupture, so that would require surgery. And occasionally a joint may need to be fused, mainly because of pain. If you have a chronic pain in a joint, you may need to fuse the joint. Okay. So surgery, it's a last resort, but can be very useful sometimes.
Okay, let's talk a little bit about prognosis. So you've mentioned that the disease left untreated gets progressively worse. Does it have good days and bad, like gout? Gout flares up and gout goes away. Does it have good days, bad days because it's rained, you've exercised, you've eaten too much salty food? I mean, is it that kind of thing, or is it really just on a consistent path?
Rheumatoid arthritis, left untreated, tends to progress. In other words, it doesn't go away, but it's characterized by what are called remissions and exacerbations. So, or maybe flares is a good word to use. So if the arthritis flares, the joints become acutely hot and swollen, and there'll be fluid inside a joint that may need to be drained. But if you use the right medications, you get less flares, they're less severe, and we can basically stop the clock on this. I might just mention that we're not only concerned about the joints, because your eyes, your mouth, you can get dry eyes, dry mouth, you can get bumps under the skin called rheumatoid nodules, you can have changes in the lung, changes in the kidneys. So this disease, untreated, is a very serious condition, and it's also associated with increased risk of cardiovascular problems. So patients with rheumatoid arthritis are at more risk of heart attacks and strokes, as well as all the other things that can happen as a result of their illness. So I can't stress too much how important it is to do something. Now that we can do something about it, we really should.
Is this the most intense, kind of the most fearful diagnosis for a patient who's coming in to see you?
Not nowadays. I think the outlook is very different than it used to be. And I think you can divide the patients up into mild, moderate, and severe arthritis. So depending on what their markers are in the blood, how much inflammation, which joints are affected, some patients have mild disease and they remain that way. And some patients are moderate, and then there are some patients, even today, who, despite these newer drugs, go on to develop permanent problems.
I see. Now, does having cancer, does having diabetes, are there other diseases that are more prone to put you into a condition where you have RA, or not necessarily?
Well, sometimes diseases occur together, but they don't cause each other. So, for example, let's say a patient is diabetic. That doesn't increase the risk of getting rheumatoid arthritis. However, a group of diseases called autoimmune diseases that, say, affect the thyroid, diabetes indeed is one form of diabetes is autoimmune. And they kind of cluster. So if you have one, you might be more prone to getting one of the others. But it's not a causal relationship. It's more that they're seen together.
Okay. Is there a lot of research being done these days to help patients with RA, or is it kind of a forgotten stepchild?
Oh gosh, no, it's not at all. It's at the forefront of research, and one of the reasons why it's so important is that the underlying mechanisms, which, for example, how inflammation comes about, affects all kinds of other diseases. And of course, that means that some of the drugs we use for rheumatoid arthritis, called the biologics, work for Crohn's disease, they work for a whole number of diseases which share a common pathway, but the end result is different. So if you can intervene with that pathway, it sheds light on immunity, on infections, on vaccinations, all kinds of things. And I think one of the things that actually made a big difference was the amount of research that was put into AIDS, HIV infection, uncovered a lot of the mysteries of the immune system. And we've put that information to work now for disease like rheumatoid arthritis. So there's a lot of research, and I don't think I would have predicted when I started practicing rheumatology that we'd be where we are today. But I'm happy to say that every year I go to the American College of Rheumatology meeting. Just about every year there's something to take home that's important.
That's wonderful to hear.
It is.
So as a future, I mean, is this a disease that you can see being pretty much eradicated 10 years from now, 20 years from now, somewhere in your lifetime, somewhere in our children's lifetime, or not necessarily?
That's a great question. And the answer is we don't know. We could wake up tomorrow and find that somebody's made a crucial breakthrough. Our hope is that someday you may be able to get some kind of therapy that will either prevent this from happening, or that you get one session or course of treatment and the disease goes away. And that's really the goal. That we're looking at that at the moment, and it would be great, of course, for patients if they could be treated and not have to continue with these diseases. But in the meantime, I think it's great that we even have got as far as we've come. That's
wonderful. Are there any messages you'd like to leave with our viewers about RA?
Well, I think being educated about your disease is very important. I think it's important to know that it's a very common disease, so if you've got symptoms, by all means go to your primary care doctor, who may well refer you to a rheumatologist for specialist treatment. It's important to know that early diagnosis is essential, and really because of the new tools. This was not as essential in the past because our options to treat were less. Nowadays we can almost always find a medication that will work for you. Very effective treatments are available, and I would say that the future going forward looks very bright. The outlook for patients with rheumatoid arthritis looks bright.
That's really good to know. Thank you so much for sharing this information,
Thank you.
and thank you for joining us.